Dr. Sachin, could you share your screen?
Yes. Can everybody hear me?
Yes, we can.
Yes, yes, yes.
Thank you, Dr. Arivalgan. That was a nice presentation for CSF shunt procedures. I would prefer optic nerve sheath fenestration for my patients, but as you correctly indicated, it depends on what the patient presents with. These are my conflicts of interest, but the most important one is that I'm no longer a surgeon. I do not do either of those two procedures. And so my opinion is going to be unbiased based on outcomes and on the pathophysiology. So let me start with a usual case presentation, something that we see at least a few times in our clinic. A 27-year-old morbidly obese female who presents with worsening headache and blurred vision with pulse synchronous tinnitus and TVOs. On examination, she has markedly reduced visual acuity and color vision and horrendous papilledema, as you can see in the pictures. The visual fields show significant constriction and reduction in both eyes. You get an MRI, which shows partially empty cella, posterior globe flattening, and MRV, which shows non-thrombotic transverse sinus stenosis. CSF opening pressure is significantly elevated at 600 millimeters of water. Contents are normal. And as Dr. Plant identified, in the US, we start at 1,000 milligrams a day with a rapid escalation planned to 4 grams per day. But she returns in 5 days with worse visual acuity, worse color vision, worse visual fields, and she's unable to go up beyond 2 grams per day because of the significant side effects which Dr. Padmaja identified as well in her practice. The question now is, you have this patient 5 days later, acute papilledema, worsening visual functions. What will you do? To me, the answer is obvious. I would prefer optic nerve sheath fenestration over a CSF shunt procedure at this time, even though I have the ability to have access to both kinds of surgeons. Let me start by pointing out why I think so based on the mechanism of action and the pathophysiology. We all know that the ICP is transmitted equally across all contiguous subarachnoid space. So, if the CSF pressure is high up here, it's going to be transmitted along the optic nerve sheath. But what you have to understand is that the ophthalmic effect is secondary to a local optic nerve head pathology. We know from the studies that Dr. Here did many years ago in the UK, actually, where he showed that increased CSF pressure may lead to ballooning of the optic nerve sheath, which now acts as an expansile vessel. We see these effects on MRI in the form of posterior globe flattening or optic nerve ectasia, or on OCT, where studies have clearly demonstrated bowing of the Brooks membrane in the peripapillary region. So when the CSF optic nerve sheath balloons out, it causes a mechanical effect by compressing the axons, compressing the blood vessels, leading to vasomotor instability, intraneuronal ischemia, and axonal death. We also know from studies done by Hans-Peter Killer many years ago that in patients with papilledema, there might be a change in the CSF physiology within the optic nerve sheath itself. It is possible that there is reduced CSF turnover, as you can see in patients without papilledema and with papilledema, and the CSF composition is changed with some inflammatory components as well. A few years ago, some of my students did a histopathologic study of the optic nerve sheath itself and found on light microscopy that there is increased cellularity. And on electron microscopy, you can see marked irregularity and disruption of the collagen compared to controls. So what this tells us is there's a lot going on right there at the optic nerve head. Now let's come to the performance of optic nerve sheath fenestration. And as Dr. Arivaldan presented, the results are really good. Most studies show that there is better than 90% improved visual outcomes in series. Even if you do one eye, there is improvement of fellow eye in at least 50 to 60% of cases. And even in patients who have a functioning shunt procedure and progressive vision loss, going ahead and doing a optic nerve sheath fenestration can preserve their vision. And as a bonus, about half of these patients may obtain headache relief. The adverse effects are there. It's a surgical procedure, but they're mostly minor. The severe visual loss, which is a dreaded complication, is rare. Importantly, the survival rates of fenestration are about 75% at 6 months, 66% at 1 year, and 38% at 5 years. And I think that is comparable to CSF shunt procedures as well. As Dr. Arivalgan pointed out, there is a hardware involved in CSF shunt procedures. Do I recommend my patients to get it done? Yes, but with the understanding that you may have to go in and redo the surgery. With optic nerve sheath fenestration, you can get immediate success because you're decompressing the optic nerve sheath right where the pathology occurs. So what happened to our patient? About 8 weeks after fenestration surgery, the visual acuity improved quite dramatically. The optic nerve swelling reduced quite dramatically. And as you can see, the visual fields are also much, much better. So thank you for your attention and happy to take any questions for the debate.
Thank you very much, Dr. Murli. Just one question. We have 6 more speakers.
Yeah, I have a question for Dr. Arivalgan. I mean, can you find out on MRI whether a shunt, a LP shunt or a VP shunt is working or it is dysfunctional? Is it possible to do that?
MR is not the best investigation to decide whether a shunt is working in idiopathic intracranial hypertension. Of course, if you're doing a shunt for some other conditions where there's a dilated ventricles, then a CT scan imaging will show. Whereas here, the patient's imaging is most often normal, where the ventricles are already small. So when you put a shunt, it's going to be symptomatic improvement and the assessment of papilledema and resolution of papilledema and the improvement of visual acuity. And if it is a VP shunt, when we put a VP shunt, there is a chamber which is present behind the ear where we do what is called a shunt tab. When there is a doubt, we can do a shunt tab where you put a needle into the chamber and aspirate CSF and check whether the proximal tube and the distal tube is functioning. So in case of VP shunt, we can do this procedure, which is basically subcutaneous needle insertion, and check. But imaging in intracranial idiopathic hypertension will not help to tell you whether a shunt is working or not. But it's primarily the patient's clinical improvement, both at of the visual acuity level as well as the resolution of papilledema. So symptoms, it's a different talk. It's a different topic. I will not get into that.
Question for Dr. Sachin. Would you do it unilaterally or bilaterally?
It depends on the amount of visual loss and the degree of papilledema. If it is asymmetrical, then one side. But if it is severe central vision loss and severe papilledema, like in our patients on both sides, where you saw that within 5 days the vision has gone down, our surgeons will do bilateral.
Thank you. We shall
Can
now.
I ask, can I ask a question? Whatever I read, I understood that the pathophysiology of the optic nerve sheath fenestration is not clear. Is that that's what I found in literature? Maybe am I wrong, or we have a clarity on how it works?
The pathophysiology of IIH, yes, that is still unclear. Correct.